The stress incontinence with incomplete bladder emptying. SUI is 49%, and it depends on which population we are taking and what definition we are looking at. As already said by all the speakers, that the initial evaluation is a must. So whenever you get a patient, it is a focused history. You should know what are the causes you have to look for and what exactly you are going to look for in the examination. PSPV examinations already done by my previous speakers. So for you to know is that full bladder assessment for SUI is a must. And if you have to advise any test, it is the urine analysis and ultrasound for the assessment of post-voidal urine. So what do we look at the urine test? Some patients might be symptomatic having a UTI, and we have to rule out that. So we look for the pus cells. We can do a dipstick or a routine test, look for the pus cells. If patient has symptoms, we can straight away start antibiotics without a culture. But if she does not have symptoms, wait for the culture. But a UTI treatment is a must. Do we need any other additional evaluation? We have just limited ourselves to a focused history with a full bladder examination, an ultrasound and a urine test. So we can go ahead with the ancillary test only if our diagnosis is not complete. If we have not been able to demonstrate SUI in our examination, or there is hematuria, pyuria, or maybe there is a pelvic organ prolapse. So everything in all we have to take into consideration. And most important is that if there are any overactive bladder symptoms, or she had a previous surgery, whether for an incontinence or a prolapse surgery. So what do? You assess the pelvic floor muscles. As we do in a routine prolapse case, we look for the levator ani and look how loose what is the tone of the perineal muscles and whether they are causing the urinary incontinence. Do we do cystoscopy and urodynamic testing only for SUI? Yes, you can do, but it is not mandatory. So cystoscopy and urodynamic studies are limited for limited conditions. So what are they? So whenever there is a mixed type of a urinary incontinence, you can go ahead with the urodynamic studies. Or if there are symptoms of voiding dysfunction, apart from SUI, go ahead. There's a pelvic organ prolapse. So you have to use your judgment and individualize the cases where you are subjecting your patients to urodynamic studies. Imaging. So apart from ultrasound, do we do a MRI, CT, X-ray? No, they are not required, only if indicated, but ultrasound is a must for the post-voidal urine. Any other tests? In our traditional teaching, we teach our students Q-tip test, Boney's test. Do we do in all the patients? So you can select your patient, because with a full bladder, you can do a Boney's, but it is not a must according to the latest guidelines. A pad testing. So do you give a pad to the patient and do you test whether she's actually leaking, which is not a must. So what is important? So the important is whatever the patient has told you, what is your examination, and look at her symptoms. Are her symptoms bothersome? Does she need treatment? So if she needs treatment, we have heard from various speakers that we can do an expectant management, we can do a behavioral management, we can do a non-surgical management, and we have various surgeries also. So depending on the symptoms and your findings, you are going to go ahead with the first line treatment and the second line treatment. In the first line treatment, we have the lifestyle modifications. So we heard from the previous speakers that we can maintain a bladder diary. So patients are not very comfortable, they'll say treatment to Urogynaecon. What is this diary? So you just give her simple instructions. Don't take too much of caffeine, don't take too much of fluid at night. You can maintain a fluid diary and a bladder diary. But if she's obese, ask her to lose weight. In case this does not happen, you have non-surgical methods also, which could be in the form of a pessary, insert, or just simple pelvic floor muscle exercises. So what are these pelvic floor muscle exercises? We already tell our patients about the Kegels exercises. This should come as a first line along with your lifestyle management. So in pelvic floor muscle training, you have to tell the patient that she has to contract 8 times, and the sittings should be at least 3 times a day. So morning, evening, morning, afternoon, evening, 3 sessions, and in each session, at least 8 contractions of the pelvic musculature should be there. Apart from that, you do not need any perimyometry or anything else. So how long will you give this? So the bladder training, the lifestyle, the perineal muscles, normally they take 3 months to give a response. But yes, you can call her after a follow-up of 6 weeks to find out if she is responding or if there's any voiding discomfort she is having. So you have to switch your management accordingly. So neurostimulations we heard in the morning that they are not to be offered as a first-line treatment. Yes, they can come as a second-line treatment in which we stimulate the nerves which are the sacral nerve, and it's a transcutaneous sacral nerve stimulation or posterior nerve stimulation. So bladder diaries, patients are not comfortable, even we are not comfortable. Our previous speaker said we are busy in the OPD, patient also. So the previous speaker said that the bladder diaries, even the doctor is busy, he does not have the time to tell how to maintain a bladder diary, and when she comes back again, there's no time to see that bladder diary, and patient will also say, koi dawai to di nahi, so what is the fun of bladder diaries? But in case you are actually into it, so it should be a part of your initial assessment with the bladder diary, and for a minimum of 3 days, you can cover all the variations of her usual activities. So can we give her some absorbent containment products, urinals or toileting aids? They are not at all recommended. But yes, if you have not given any definitive management and there is time for your ongoing therapy, you can offer this, but this is not a first-line treatment. So what medication pharmacotherapy can we give to these patients? So we heard with the previous speaker that with the overactive bladder, we can give some agents. So before giving any agent, you have to tell her the success rate. You have to tell her about the side effects, because anti-muscarinic agents, anti-colinary agents, they do cause dry mouth, constipation. You have to match with what age she is and what concomitant other medical problems she is facing. So you start a therapy, not before 4 weeks there will be any beneficial effects. So you can offer them, because they're very costly, you can offer a low-cost therapy. And desmopressin is a reserved drug which is given only to patients if there is nocturia, overactive bladder, but keep in mind the other conditions, cystic fibrosis and her age, the cognitive functions, the hypertension. So before giving any drugs, rule out the contraindications and then start the therapy. So when do you follow up these patients? These patients, if they receive a good response, you can call them after a year. Find out how much is the assessment of continence and whether she is responding, or any further new symptoms have come up, new different comorbidities she is facing. So accordingly you decide. So what about the surgical management? So your first line management was lifestyle, then was your medical management. Can you go ahead with the surgical management? Yes. The risks and benefits to be conveyed to the patient, a shared decision to be done. And what form of surgeries we've already heard. It could be the mid-urethral slings, it could be the autologous fascia, it could be a Bursch surgery, or even we can inject some bulking agents near the urethra. So we have a variety of surgical treatments. You see what the patient wants, what is the success rate of each surgery. And these surgeries have already been explained. The retropubic, the transobturator slings and single incision slings. So these days the mesh is going out of use, the autologous fascia is coming in, and let's see the results. So what do you do? Stem cell therapy if nothing is working. So stem cell therapy is not a good management for stress urinary incontinence. So what do you do if there's a fixed immobile urethra and they do wish to have some kind of a surgical treatment? You can offer them a retropubic urethral sling, because the urethra is immobile. Don't go in for TOTs, or you can give a urethral bulking agents. So if you have, please avoid using the use of mesh if patient is going for a SUI surgery and on top of that she has a poor wound healing. What do we mean by poor wound healing? Patients who have been exposed to radiotherapy and chemotherapy, who whose quality of tissues are bad, so don't offer them. In patients who have a PO, who have a prolapse, along with SUI, earlier we were doing a Kelly stitch, but you can do a mesh surgery along with it, or you can even combine with Bursch. So what do we do after we have done the surgeries? Again, these patients need a follow-up because immediately no patient will improve. And once the patient comes back, again you have to take the history, a proper physical examination, and maybe an ultrasound to find out what is the residual urine.